Flora, for this kind invitation. And I thank also the organizations to invite me here. It's for me very impressive to see this morning all these problems you have, and I'm old enough that I know the problems of the treatment in the beginning when I started in 1975 in Germany. And we still had there the older people, and I had also the problem of the joint disease. And I have a twinning with Costa Rica, with a country of also the third world. And for me, it's very impressive. They improved from 0.2 units per capita now to more than 2. And I think one of the things behind this is it's a country without an army. And the population voted against the army, and so they have more money for education and for the health system. So if I tell you something about treatment and prevention of inhibitors, it's difficult because I know most of these things you cannot do. Nevertheless, the treatment of hemophilia, and I think this is especially for the patients, it should be the aim to prevent bleeds, to treat the bleeding episodes and the complications and their consecutive damages. And what is very important, especially if you have to treat young patients who have no severe joint disease, to conserve these joints and maybe, as you have seen from Hungary, to cure the joint function. And with this, you can integrate the patients into a normal social life. So the arthropathy is the disease of the joints, and you have repeated joint bleeds in the hemophilic arthropathy, which means pain. And this is often forgotten, even in children. Children have pain, even if they don't say it always. If you ask them, or if you touch a joint where you have had a bleed or you have subsequent small bleeds, you will realize it. You only have to take your fingers and press them on the joint and the interspace between the two bones, then you will feel it and they will tell it to you. We have learned a lot about the disease, and I think we know that more the hypertrophy of the synovial is done by synovial cell hyperplasia and the proliferation of capillaries. Not so much about the proliferating of this done like in rheumatic disease. And the cause of this is the blood that is inside, and especially the iron. The iron destroys a lot. And in our setting, we are using now much more a puncture of joints to take out the blood if there is a severe bleed than we have done it before. I was very happy that Laszlo Nemes was telling about the radiosynoviotasis. This is also a method that was forgotten, I think, in Europe, with the access to a lot of factor concentrates. In countries where you have not as much factor concentrates, this is a very good method to keep the joint functioning. So if you treat hemophilia, you have these risk factors, and you have seen this morning the problem of crippling. If you have to pay for your factor, you will become easily poor. And still nowadays, patients bleed to death. Even in our country, we have the problem that some of our patients every year bleed to death because of not an adequate or immediate treatment. The risk of virus infections in countries where you have concentrates, I think, is done, and we don't know whether the variant Creutzfeldt-Jakob disease will really play a role in the future. But the big problem nowadays is still the development of inhibitors, which is much more the case in hemophilia A than in hemophilia B. And we do not know everything about this inhibitor development. We know that we have factor VIII, and this factor VIII is foreign protein for the patient, and we know that in the past some patients will develop inhibitors and some will not. But the reason why they do one or the other, we don't know very exactly. But we know that most of the inhibitors develop in a very early stage. So it is very important to look for inhibitors in the first 20 to 50 exposure days. For the treatment, we have two strategies. One is the on-demand, especially if you have not enough amount of factor concentrates. You will treat with clotting factor concentrates in the case of bleedings. And on the other hand, the state of the art for the hemophilic patients would be a prophylaxis. And I think the prophylaxis should not end after puberty. It should be lasting also in adult patients. I always say to our students, in a child with severe diabetes, you will not stop the treatment when they are adults. You have to continue this. We have different modes of prophylaxis. We have the primary prophylaxis, which starts after the first joint bleed and before the age of 2 years, which is done in many of the Western countries. The primary B, which starts without previous joint bleed and before the age of 2 years. And I will show you later, we are doing a special version of this primary B prophylaxis and the secondary prophylaxis, which is done after more joint bleeds or an older age, or you can do it intermittent for treatment of a target joint, for example. So the benefits are clear. The prophylaxis has proven to reduce the bleeding frequency, especially the work of Dr. Manko Johnson has shown that not only the joint bleeds, but also the total number of bleeds is reduced. And you have a 6-fold decreased risk of MRI-detected joint damage. It also may reduce other morbidities like intracranial hemorrhages. And if you start early, we are convinced that you can avoid or reduce the number of inhibitors. And with this, you can improve the quality of life and productivity and may reduce the healthcare utilization. So prophylaxis has two aspects. One is this, what I said before, the prevention of the joint disease. But on the other hand, maybe if you avoid danger signals, which are conserved patterns on pathogens and on altered or damaged self, that's the injured or the dying cells, they are alarming and triggering the immune system into action. And they can efficiently prime the adaptive immunity. Initiation of a factor VIII replacement without danger signals in patients with severe hemophilia A might lead to a tolerization. I don't know whether you can read this all. This should show you that you have different risk factors, and especially we have genetic risk factors for inhibitor development. And we know that the severe mutations have a higher risk to build inhibitors than other mutations. And so we can group our patients in low-risk patients or high-risk patients from the genetics. And the question is whether we are able to change a high-risk genetic patients by maybe early prophylaxis in the absence of danger signals to a low-risk patient. And this is something what we try to do. And why we are doing this, there are some hints in the literature that this can be the case. One is the canal study, which shows that prophylaxis has a risk decrease of 60%. But the same results are seen in a study from Frankfurt, from Dr. Escoyola, from Spain, from Dr. Morado. It's a single center study again. And in Italy, you have also some of these results which show that the risk of inhibitor development is multifold. So you have, for example, in this very nice work from Elena Sant'Agostino, the risk factor of a positive family risk history is 9.5 compared to a high risk of genetic, like intron 22 inversion, one of the most often genetic mutation, it's 2.8. But if you start your prophylaxis after 20 exposure days, this is higher. It's nearly half of the family history. So this is something you have to think of. And in the canal study that was convincing me and Karin Kurnik from Munich, there was a very interesting thing that if the treatment for the first treatment period is more than 5 days, the risk of inhibitor increases fourfold. If you use a high dosage, which is very often in small children, that you use maybe only 500 units, you have it maybe, then you have easily more than 50 units per kilogram, you have also an increase fourfold. And if you put both together, more than 5 days and a high dosage, you have a high risk of inhibitor development. And this is seen, for example, in our patients who have an intracranial bleed. These patients are usually treated with high dosages for a minimum of usually 10 days. And all of these children in our settings, and I know it from some other centers in Germany, 100% of them developed inhibitors. So this is a high risk. On the other hand, if you have a regular prophylaxis, this risk is less. And you can see the risk is especially done with surgical procedures. So we try to avoid surgical procedures in the beginning of the treatment. Another thing, the canal study was showing that the change of concentrate has no influence on the inhibitor risk. So we have if you have changed the concentrates, it is not increasing. Matzinger was telling us that there is a danger model. And this danger model, I think it's a model, but it's very good explaining what happens. If you have a distressed cell and if you have a bleed, for example, cells are dying and these are distressed, the distressed cell will do an alarm signal. And for the antigen-presenting cell, which is now proposed with a foreign protein like factor VIII, this will propose this to a T helper cell. And the T helper cell has two possibilities. One is to have no activation and get tolerance, and the other is to activate the B cells and have maybe an antibody response. So this is the same. You have the danger signal, you have the dendritic cell, which is a cell that is cutting the factor VIII into peptides and will present this to the naive CD4 T cell. And together with this danger signal, you have a co-stimulation with cytokines, and you have the full repertoire of activation of this T cell, and this activated T cell can now drives antibody responses in B cells. If you have no danger signal and the absence of the co-stimulation, this naive CD4 T cell will not be activated, and it can be either apoptotic or tolerogenic to CD4 T cells, and that suppresses the antibody response in B cells. So how can we avoid danger signals? We should not treat into a severe bleed or during an infection, if possible. We should avoid surgery within the first 20 or 40 exposure days. We should not vaccinate at a factor VIII treatment day, and we should vaccinate subcutaneously instead of intramuscular, and start early with prophylaxis. So the recommended prophylaxis regimens are 3 times per week, up to 50 units per kilogram. Start with or after the first joint bleed, and often for this, the Porter-Cat implementation via surgery is necessary. So you have the potential danger factors. That's a high dose. We have seen the bleeds and surgery and bleeds and infections. So in this time scale, we have the first 2 years of a child. And in our new prophylactic regimen, we would see a chance to start with a treatment when the first soft tissue bleeds with about 10 months are occurring. These are bleeds we usually in the past did not treat. But now we start this, and we think without a lot of severe bleeds, which are coming later in the second year, the joint bleeds, we have a chance to tolerize the patient, and also we have a prophylactic treatment for this time. We never have seen in our cohort any intracranial bleed in patients who are on early prophylaxis. We start with a once weekly about 25 units per kilogram. Why 25? This is the smallest amount we can have with 250 units in a vial. And when the bleeding frequency is higher, then we go up to twice weekly, the same dose, and even to 3 times per week. And then continuously we are adapting to the bleeding frequency of the patient and get maybe a more joint protection phase. In our old work from, you can see it was published in 2010 for the first time, we had 70 consecutive PUBs included. 30 were the old control group, 40 the study group, and this is a standard prophylaxis. And you can see in the standard prophylaxis we had 47% inhibitors in these severe consecutive patients. And then in the study groups we have a new prophylaxis regimen, which I showed you before, with 200 units once weekly. And the big difference is here we started after 1 exposure day, here after 30 exposure days, and we had only 1 low titer inhibitor. Now we have even more than this. We have more than 60 patients and still have 3 inhibitor patients. So this is a big difference, and it was very nice to see Laszlo Nemes this morning, because Hungary is doing the same scheme, and they could reduce in the whole country the inhibitor frequency drastically. So this is the same. You can see here in the old group we had 8 high responders, 6 low responders. This was only a low responder. The other 2 we have now are high responders. If you look for the genetic factors, and that's the important thing, all these patients were severe hemophiliacs, all were Caucasians. This could be a bias. And if you look for the mutation type, we have no significant difference between high-risk mutations and low-risk mutations. So we would propose to start on demand, maybe with 1 injection if you have a bleed, and then if you have hematomas or minor soft tissue bleeds, continue with once 250 units per week, this prophylaxis. If the patient is bleeding, or if he has more than 5 exposure days before, we would start with 2 times 250 units per week. And if you have major bleeds or severe bleeds, you continue with 3 times 250 units. In special cases, maybe you can use, if you have not a very good venous access, with 2 times 500 units per week. But this is more than 2 times here or 3 times 250. From the economic aspect, you should do this with a low dosage. The big problem of this is the venous access in small children. And we try to do home treatment, and we train the parents very early. And we avoid in most of our children the port insertion or the arteriovenous fistula. And you can see that the patients can be treated. This is a patient who is 13 months, and the mother is doing it together with the grandmother, and the nurse is helping them. And she did it for the first time when the child was 1 week after the first birthday, and she did it at home. So the most important factors appear to be the reason for the first infusion at a young age and the intensity of treatment. In these situations, the immune system may be exposed to the deficient factor with the context of immune system changes and the occurrence of danger signals. And recent data suggest that prophylaxis might modulate the immune response to treatment when started at a young age and therefore reduce the risk of inhibitor development. And in the long term, from the economic aspect, you are cheaper. Because if you can avoid inhibitors, if you can treat inhibitor patients with bypassing agents, it's a very costly thing. And if you can avoid them, this early prophylaxis in maybe after 5 years or after 10 years is much cheaper. So in my last part, I will look for the current treatment regimens of ITI. I think the long-term prophylaxis with the APCC or recombinant factor 7A in order to prevent bleeding or the hemophilic arthropathy and life-threatening bleeds is something that is necessary. And to avoid a long time of very costly treatment, rapid inhibitor elimination and immune tolerance is preferred as a way to reduce the high risk of bleeding episodes. There are various therapeutic methods to do this in our centers in Germany, and especially we publish this also from Frankfurt and Bremen. We are testing for inhibitors every 3 to 5 exposure days in the beginning. That means in the first 20 exposure days. This is important to detect the inhibitor early. And if we see a high titer inhibitor, and this is approved by a second blood sample, we stop the administration of factor VIII, and immediately we start with ITI. And we start in our country, according to the Bonn protocol, with 2 times 100 units per kilo per body weight, with the same product the patient was treated before. And if necessary, here we implant a central line to have a good access for the veins, and this is done by a bypassing agent. And when we have no decline of the inhibitor of more than 30% after 6 to 8 weeks, we change our factor VIII concentrate to a von Willebrand factor containing concentrate. And then we continue. If the 12 hours half-life and recovery become normal, we decline the factor VIII administration in steps of 250 units every 2 to 4 weeks, down to about 2 times 50 units per kilogram every day. And if we have this and the half-life and the recovery still is normal, we switch to 100 units per kilogram once daily. This is the biggest step for our patients because they have only to be treated once daily then. And then we continue with this, and after reaching 50 units per kilo per day, and we still have the no inhibitor, we switch to 100 units every other day, and then we still reduce these doses up to a dose of 40 to 50 units per kilogram every other day, which is a high-dose prophylaxis. But then the child is growing, and by himself, the dose is lowering. And we continue this for maybe 1 to 2 years. And if the patient or the mother want to switch to another von Willebrand factor containing concentrate with less solution volume, or to another maybe a recombinant concentrate, we allow this. But we look very good for bleeds, and we look for the inhibitor development. So you have, after 2 and 4 weeks, look for a new inhibitor. And if bleeds occur during the ITI therapy, a treatment on demand is done with a bypassing agent until the bleed is completely resolved. This is very important. And in patients with a high bleeding tendency, we do a prophylactic treatment with a bypassing agent. And in small children, you have to keep in mind that the dose for the recombinant 7A needs to be higher because of the lower or the amount of recombinant 7A is not as good in these small children compared to adults. The results of our study in Bremen and in Bonn, we included 21 patients, 16 high responders, 5 low responders. These are old data, and the age was between 0.4 and 6. And the definition of success is very important. If you look for these studies, you need a no detectable inhibitor, normal recovery and half-life, and no reappearance under prophylaxis. And we were successful in 100% in the low responders and 87% in the high responders. And we had the same time to eliminate the inhibitor like Laszlo Nemes showed you from Hungary. So if you look for the international ITI success rate in hemophilia A, you can see a lot of studies, and you see the results are different in the success rate. Our success rate was quite good. If you look to this, you could say this is much better, but the definition of success in the Van Creveld study is quite different. They accepted a low inhibitor of maybe 2 Bethesda units as success. So this is important if you compare these studies. We have some predictors of outcome. That one is the host factors and the treatment factors. It seems to be very good if you have at the beginning inhibitor titer that is less than 10 Bethesda units. We know that patients with a historical peak titer of more than 200 Bethesda units have a bad outcome. Also, if you have a very high peak titer on ITI, on the other hand, the low peak titer is a good outcome, and we don't know very much about the ethnicity. And we have treatment factors, the lower age at start of ITI, maybe infections. This in the international study, this did not play a big role. Also the immediate or delayed start. For me, the immediate start has 2 important roles. First, you have treatment in these patients, so they are not at the big risk of intracranial bleeds. And you know, in the international ITI study, they lost 1 patient in the waiting period because of an intracranial bleed. And on the other hand, if you wait for more than 1 or 2 years, the patient or the child will have maybe much more weight and you need much more concentrate. I have the impression that the interruption is not good, but in the international study, this was not seen. And the concentrate is, you can see a lot of different treatment regimens. I think the old Bonn regime showed at now the best results for this. And if you look for the time for tolerance, you can see here from the international ITI study, the low dose and the high dose, and the reason why the study was stopped was while the low dose had much longer time to get immune tolerance and a lot of bleeds in this time. So the bleeds play a big role, and here you can see in this international study, 29 subjects were bleed-free throughout the ITI, 8 low-dose and 21 high-dose patients, and that was important, and they had a lot of hospitalizations for bleeding, especially in the low-dose regimen. So in conclusion, in good risk patients, similar efficacy with high and low-dose ITI, 50% longer to achieve tolerance with the low dose, and the PK suggests some patients may have stable partial tolerance. The similar infection risk between the treatment arms, so in this study no effect of infection on efficacy could be seen, and more bleeding in the low dose arm, and the pharmacoeconomic analysis is still in progress. And now I thank you very much for your attention. This is a picture also from Costa Rica, and they show the alternative medicine. Maybe this is the access you have in Romania sometimes, that you have herbs which are good for menorrhagia and for light bleeding disease, but is not the right therapy for the patients with hemophilia. Thank you very much.